Hello, ladies and gentlemen. Uh, Greetings to all of you from the IAGES organization. Um, Now, let me first start off by thanking IAGES for giving me this opportunity to wrap up this session, the HPB session of the INDO-UK Surgicon 2020. I hope all of you have enjoyed listening to these lectures, the recorded lectures, as much as you have enjoyed the real conference in October 2020. And I have to say it was an absolute privilege and pleasure and honor for me to have been the scientific committee secretary for this historical conference. Um, I, I thank the president and the IAGES committee for having bestowed that responsibility on me. And I have to admit that I would not have been able to deliver my duties in compiling this scientific program without the help, advice, guidance of all my colleagues and seniors within IAGES, and I immensely thank them for that. Just to give you a bit of a background of this scientific program, we actually started preparing on the scientific program some 10 or 11 months before the actual conference. We had initially designed it for the real conference, but unfortunately, COVID pandemic broke out, and so we had to redesign the program to fit in with a virtual conference. And that was quite challenging because we none of us had much of experience about conducting virtual conferences, and there was no precedent to it. So many of us were learning along the way about how to get this conference as lively and as interesting as possible. So we had several brainstorming sessions. Many of us we got together. I think we must have had about 10 or 15 meetings over a period of 6 months before we decided on this final scientific program, which I hope all of you would have liked. And we tried to keep this scientific program as balanced as possible. In keeping with the motto of IAGES, we wanted to make sure that there's an equal representation of all subspecialties. So it was a 2-day conference. We tried to divide the time equally. We divided the entire conference into 8 subheadings. Hernia, colorectal, endoscopy, and upper GI on day 1, general laparoscopy, bariatric, HPB, and robotics on day 2. And we also ensured that the pattern for each of those subheadings was exactly the same, so that there is no discrepancy, so that the audience gets a good flavor of the various specialties that they're interested in. And it was challenging because it was almost like having four conferences in parallel on one day, and like having 8 different themed conferences over a period of 2 days. But I'm happy that it went on well, and we had thousands of delegates logged in from not just from India but from all over the world, and the feedback that we received was excellent. And I thank everybody who has been behind this conference to make it a grand success. On top of that, I would also like to add that we had a number of free papers submitted to us in the form of abstracts from trainees, again from all over the world. Unfortunately, the timing was limited, so we could only accommodate 4 free papers in one subheading. So that left with almost 100 to 150 free papers, which we had to leave out. But then we thought we should give them a platform to present. And so between sessions, we had a number of trainees present their work, and they were also marked by a team of judges, and prizes were given towards the end of the conference. There was a lot of hard work which went behind the scientific program, and it is a team effort, and I thank each and everyone who's been behind this work to make this conference a grand success. And I hope you're continuing to enjoy the recordings of this conference, which is being telecasted now and over the last few weeks. With regards to the HPB session, I'm happy to say that in addition to being the scientific committee secretary, I was also given the extra responsibility of working closely with my colleague, Dr. Rajesh Gurjwani, to coordinate the HPB session of the conference on day 2. And as you may have already noted, it was a program with lots of variety in it. There was plenty of lectures on laparoscopic hepatic surgery, laparoscopic pancreatic surgery, splenectomies, and there was a very interesting debate. There was a very interesting panel discussion too, and I hope all of you have thoroughly enjoyed all the sessions in the HPB part of this conference. And in the last few days, you have listened to these lectures, and a few questions have come up, and I thought I would just briefly try to answer these questions. The first of which was on the role of hepaticoduodenostomy as a reconstruction procedure after choledochal excisions. I think the question was about whether hepaticoduodenostomy was better or worse than hepaticojejunostomy. Well, it is a debatable topic, but what the literature says about this is that hepaticoduodenostomy is definitely an easier procedure to perform. It takes less operating time. There's faster return of bowel function after hepaticoduodenostomy in comparison to a hepaticojejunostomy, and it's more of a physiological anastomosis, and it's associated with less incidence of adhesive small bowel obstruction and less incidence of anastomotic leakage. So certainly there are lots of benefits with that. However, the question of whether there's any role of this procedure in adults, well, almost all the papers that I have gone through are talking about this procedure in children, so I'm not aware of any papers that say hepaticoduodenostomy is better than hepaticojejunostomy when it comes to choledochal cyst excisions in adults. I hope that answers your question. The next question was on the recent technological advancements in hydatid cysts management, liver hydatid cysts management. Well, there are a number of acronyms, a number of abbreviations that have been described in world literature when it comes to minimally invasive techniques for hydatid cysts management. Just to name a few, there's PAIR, which is probably the most popular one, which stands for puncture, aspiration, injection, and reaspiration. There's also something called percutaneous evacuation of cystic contents, PVAC, and there's something called modified catheterization technique called MOCAT, M-O-C-A-T. Now, these are minimally invasive techniques, no doubt. However, the literature is very clear about when you should use these techniques and when you shouldn't. The criteria is that the hepatic hydatid cyst lesions, they have to be less than 5 centimeters, and they should not be calcified cysts. They should not be inactive cysts. And also, these kind of minimally invasive percutaneous techniques are not advisable for, or in fact, it's a contraindication if the cyst is communicating with the biliary tree. And of course, these are not appropriate for recurrent cysts. So the answer to your question is definitely a role for these procedures. However, the surgeon or the clinician, for that matter, physician or surgeon, or they need to be very careful about how they choose their patients for these procedures. The other question was on persistent biliary fistulas. I presume the questioner is talking about a biliary fistula that is ongoing for several weeks after a bile duct injury that was sustained during a laparoscopic cholecystectomy. Well, the short answer to that is yes, surgery is the way forward, because I assume that this patient has already had an ERCP, stenting, and the endoscopist has also tried a bridging stent, and that hasn't worked. And there is a drain placed in the subhepatic fossa, and there's an ongoing bile leakage, and there is radiological confirmation of major bile duct injury. So yes, so the answer to that question is yes, this patient will require surgery, will require some form of biliary reconstruction surgery. But what I would like to emphasize here is that when it comes to biliary reconstruction surgery, the timing of it is extremely important. The literature says that if a bile duct injury is sustained at the time of laparoscopic cholecystectomy, the best repair is done by an expert surgeon then and there. An immediate recognition followed by an immediate repair by the most experienced, the best surgeon, hepatobiliary surgeon, gives the best results. However, logistically, that may not be always possible, because you may not have an expert hepatobiliary surgeon to do the procedure when the injury occurs in every hospital, and therefore the discussion goes to other aspects as to what should be done then and what should be done thereafter. Well, the standard teaching is, if the injury has happened, you place a drain and you send the patient to a tertiary referral center, and subsequently the patient has proper evaluation of the biliary injury, and the repair is performed. Now, there's debate about what would be the ideal time to do it, whether it is 6 weeks or 4 weeks or 2 months. Well, more than yes, we can go on discussing about that, but what has been universally agreed is that whatever time you take the patient back to theatre, it's extremely important that the collections, as much as possible, the collections are drained. As much as possible, the inflammation and the infection component is reduced, and the patient's nutritional condition is as good as possible. So if these three things are taken care of, and if there is expert surgeon available, and if the patient is in a tertiary referral center, the biliary reconstruction surgery can go ahead. So I hope I have answered those three questions that have come along in the last few days during this recording. And again, I thank all of you who have logged in and who have been watching these programs. So lastly, I just want to use this platform to pass on a message. The Honorary Secretary has asked me to inform all of you that the online IAGES courses will be resuming shortly, possibly within a month or so, after a short period after a short gap over the last few months. And further information regarding those courses will be available on the website IAGES.in. If any of you is interested in applying for those courses, please visit the websites or please get in touch with the Honorary Secretary of IAGES. Once again, I thank all of you for participating in the programs, and I hope this was beneficial for you. Thank you very much for your attention.
Thank you, Professor Udwaliya sir, for your passion for perfection, courage, and conviction. We move on to the next oration. It's to be given by our IPSIS president, the International Federation of Society of Endoscopic Surgeons, Dr. Zundel, a Colombian surgeon by birth, but a global surgeon by his sheer hard work. I'm sure he is going to take the inspiration and give all the inspiration to the youngsters across the globe by his oration. To do the introduction and do the honors, I invite our president of IAGES, Dr. Raman Goyal. Over to you, sir.
Friends, it's my great privilege and honor to present Dr. Natan Zundel, currently the president of IPSIS, to deliver the presidential oration during Indo-UK Surgicon 2020, jointly organized by IAGES and the Royal College of Surgeons, Edinburgh. He is the clinical professor of surgery at the Department of Surgery, University at Buffalo, New York, and also functions as bariatric surgeon at Jackson North Medical Center in Miami. Dr. Zundel has extensive experience with minimally invasive and bariatric surgical procedures. He is an active member of the following societies, namely American College of Surgeons, IAGES, IFSO, IPSIS, and American Society of Gastroenterology. Dr. Zundel has served as active honorary member of surgical, laparoscopic, and bariatric societies in 44 countries around the world. He was the president of several international surgical societies and meetings, including the World Congress of Endoscopic Surgery in 2012, International Federation for Obesity Surgery 2015-16, and the Latin American chapter of IFSO 2013-15. He currently serves as president and governor for the ACS South Florida chapter. Dr. Zundel was elected executive director of FILAC on March 2017, a federation that comprises around 30,000 general surgeons from Latin America for the next 4 years. He has published extensively in peer-reviewed journals, book chapters, and other educational platforms. He currently serves on several editorial boards, including Bariatric Times, Surgery for Obesity and Related Diseases, Obesity Surgery, Surgical Laparoscopy, Endoscopy, Surgical Endoscopy. Dr. Zundel has lectured extensively all over the world on minimally invasive and bariatric topics. He also trained and proctored hundreds of surgeons, fellows, and surgical residents on bariatric and minimally invasive procedures. Dr. Zundel was awarded the academic rank of Professor of Surgery at various universities in 4 different countries. He received now the biggest honor for a surgeon in his native country, Masters of Colombian Surgery 2020. Ladies and gentlemen, it's a great honor and privilege to present before you Dr. Natan Zundel to deliver the presidential oration on the endoscopic management of bariatric complications during Indo-UK Surgicon 2020 conference on this day, 16th October 2020.
Raman, thank you for the presentation. You took most of my time, so I don't have to make my lecture now. Thank you very much. Thank you for the invitation for the society, because not only it's a pleasure to be here, but also I had the opportunity to hear the presentation of my friend from many years, the Hampton. It was very inspiring. I see friends like Pradeep here, so it is a pleasure for me to be here. And I'm gonna share my screen. Thank you very much. So I've been asked to discuss a little bit about the endoscopic management of what only in America we call adverse events, but it's complications. So this is my disclosure of any companies that I can mention here before. So let's start with the easy one, that is the band. We know that since it was approved only in the US, more than 300 bands have been performed in the world. And we know that the difficulties with the band can rise up to major complication 40% at 10 years, revisional rates up to 30%. So there are some that endoscopy cannot do much, like the band prolapse. Most of these one we deflate them and ended up removing the band and converted to a sleeve or a bypass. When we have reflux of motility disorders, endoscopy cannot do much also. We need to remove this band. Even that I learned that most of this reflux is not reflux. It's stasis, but cause pouchitis and cause also inflammation of the esophagus, so the band has to be removed. Endoscopy play a role in here. Endoscopy play a big role in band erosions. And band erosions have been reported up to 3%, but our group who did almost 4,000 bands since 1995, we know that erosion can go up to 11% with time if you don't remove the band in the first 10 years. So we decided not to take these patients anymore to surgery. And I'm not going to show you the regular endoscopic removal of a band because we do that every day. We published more than 10 years ago how to remove a band by endoscopy. But I want you to show you other stuff that we're doing that maybe is more interesting is band that just have not eroded enough. They just even have a very small erosion like this one, and bands that you assume you better take. You see very small erosion there. This band you think you need to take to surgery to remove it. We're doing some knife surgery in those ones. We inflate as much as we can the band to create some pressure. And then we go by surgery, and then we just above the band, like we will do in surgery, we make the band appear more by endoscopy. Then, as you know, when you have more than 30% of the band in your view, including the belt, we do that. 4 days later, we come back, and then we finish this removal, and then you will be able to remove it later with erosion. Some groups are doing something different. We did it before. Some groups inflate the band as much as they can, and they put a stent, and they remove the stent after 7 days. The contact between the stent and the band inflated create that erosion. We find this be safer, and then you can remove the band, as you can see here. So you don't have to take these patients to surgery. And then 3 to 6 months later, you can convert this procedure to whatever you want, and the band is not there anymore. What about the other bariatric procedures? So even that the sleeve is the new girl in town, the bypass is still done, at least in the US, 17%. There are 2 countries in the world that are still doing more bypass than the sleeve, and that is Brazil and Swiss. So there are a number of problems you can have there. For me, it's important if they are early, they are late, or they are big, or they are not that big. In the bypass, and now some of the SADIs and one anastomosis gastric bypass, you need to define if the complications are surgical or metabolic. For metabolic, we cannot do that much for endoscopy. There is a lot of problem that can happen there. And for that, I only have this solution. So if the problem is metabolic, look for the origin. That's a very easy thing to do. So look what is going on and repair that one. But if the problem is surgical, cannot be that easy. And as you recall, or many of you have done bariatric surgery, you know that there are many places, many things that can happen in a bypass, and it can happen since day one until the day you die. Because you never away from complications when you have a bypass, and that is the reason people more to the sleeve. Some of the patients ask it more because they don't want to have that problem in their minds. So bleeding, we can do a lot by endoscopy, but we need to differentiate if it's acute, that will be intraluminal or intraabdominal. Sometimes for intraabdominal, we cannot do that much. Intraluminal, we can do a lot. And when it's chronic, we need to figure it out what happening is there. And endoscopy probably will help us find ulcers, marginal ulcers, that we can do something. We also need to find out what will be the location, because this can bleed, especially acutely, anywhere where you have staplers, anywhere you have anastomosis, remanent, etc. So we need to find out where it is, and if we can reach with the scope. If we can reach with the scope, we can treat it by endoscopy. The chronic ones, we can go with the scope. Some we can treat, some no. We just started a study where we are going to suture. We already done 2 cases, no more, of marginal ulcer that we suture with endoscopic suturing devices and see how it goes. And we cannot publish now because we don't have it yet. But when you have leaks, that is the next problem. When you have a leak of the bypass, when you have a leak of the sleeve, I love the leak of the bypasses. Most of the leak of the bypass, you just need to observe. You just need to make sure you have some good drainage. You stop anticoagulation. Most of these patients, they don't need anything else. So this is how we do it, and we published this when I was at the Cleveland Clinic with Raul's group. If you have no drains, you just put a drain. If you cannot drain it, you go to the OR, you put drains, and you do a gastrostomy because you are in the OR. If the patient is unstable, you need to take it to the OR. If the patient is stable, antibiotics, stent is needed, observation. The bypass leaks are not a problem. In my own experience, most of them close very quick and without complications. If you have to go to surgery, people have to put stitches, etc. Nothing works. It's just you go there because you couldn't drain properly. That will be the only reason to go there. Strictures also are much easier to treat with the bypass. And most of them, I would say close to 95% of them, you can treat with endoscopy. So when we look at our surgical anastomosis, we like them 1.3, like 30 millimeters, 15 maximum. When you go by endoscopy, anything below 10 or 9 is a strictures. So we go by fluoroscopy and we go by endoscopy. We try to mix them both, and we're gonna do balloon dilations. But let me tell you, I'm gonna show you a balloon dilation. Look at these strictures. This patient cannot eat anything, can barely tolerate some fluid, is vomiting, regurgitation. You go by balloon dilation, and you like it when it bleeds a little bit, and then you can restore the size of the anastomosis. In my own experience, a different of the sleeve, in bypasses, I rather dilate with non-balloon. I dilate with the regular budgies, and I keep advancing my budgies until I find the size I want. I find it that they stay longer, that they need less interventions, but that will be me, and I cannot teach that because it's not the standard of care. The standard of care is balloons, so I show you balloons. The next problem that we have very common is biliary tract complications. What you're gonna have problems depends on the type of surgery. When you have the sleeve, you do the standard ERCP. When you have a lap band or VSG, you do the standard ERCP. Sometimes you need to do some dilation. When you have a bypass, then you need to stop and think about it because, as you know, it's totally different what you have to do. I want to show you what we're doing different. I know everybody will tell you go by surgery, do a gastrostomy, and do the ERCP. Yes, you can do that, and we've done that, and we published that. But there are some things that we can do now in endoscopy. Some are nice, some are crazy, but I'm going to mention what we have been working with. So single and double balloon enteroscopy, it will allow us now to reach much easier the papilla, even with a bypass, and we can reach and do the ERCP. So Peters published a long time ago that you can do again the ERCP via gastrostomy. But again, you can get problem with endoscopy. Sorry, we can get problem with endoscopy. We can get problem with the ERCP. I didn't show you something that maybe was important, but some groups are doing now perforation and stent between the pouch and the remanent. And that way they can go through the stent and do the ERCP. We as bariatric surgeons don't like it because now you create a gastrogastric fistula that if it doesn't close, you're gonna regain weight and have all that. This is the sleeve. Imagine, guys, this is the sleeve. The new new girl in town, best operation ever. Everybody want one? And if you hear the expert today, you can cure diabetes, you can cure any metabolic problem, migraine with a sleep. He's Superman. Yeah. Don't believe everything they tell you, you know, so we're gonna see a lot of problem with the sleep. I mean, it doesn't matter who promote it. We know that we're gonna have a big stricture rate, we're gonna have a lot of reflux, we're gonna have a lot of problem with the sleep. So my biggest concern, I mean, for morbidity, it's the leaks that we're gonna discuss later, but for what is gonna destroy the sleep if we are not careful will be the reflux. Because the reflux can be published up to 20% in some publications. This one for me is one of the most significant publications from reflux and the sleeve and the bypass. Look at this. If you see the above line, it doesn't matter, yes. GERD is much worse with sleeve. You cannot solve really reflux when you do a sleeve. We can resolve a lot if you do a bypass. It's not perfect, but it's better. But if you see the table below, is if you have reflux before the sleeve or you didn't have reflux before the sleeve, look at the difference in these three parameters. If you have reflux before sleeve, complications are higher, revisions are higher, and you fail more in half weight loss. So not only you're gonna have more problems, but you can also have more failures. So reflux before the sleeve, if it's significant reflux, should be a no indication to do a sleeve. This is, we published this already 2 times, the last one in the book of the perfect sleeve. We needed to develop our own algorithm to try reflux after the sleeve, and then I'm gonna show you what we do. Because it's so complex, the problem, that converting to a bypass is the easy solution. But when you see a lot of these patients, as we do, because we get a lot of referral for many places, most of the patients, they did go to the sleeve because they didn't want to bypass. And now you tell them after 6 months, 1 year, that now they need a bypass. They don't accept it. So if the patient have normal anatomy with good weight loss, we give them conservative treatment. If it works, we don't do anything else. If it doesn't work, we do 2 types of endoscopic interventions. We do dilation of the sleeve to reduce the pressure with balloons, achalasia balloons, and we do radiofrequency like a stretta to increase the pressure of the sphincter. I don't like a stretta for primaries, but it works well when you have this type of problem. If it doesn't work, we convert. But why I'm gonna try to change normal anatomy and good weight loss, we just need to focus in the reflux. If you have abnormal anatomy and you have inadequate weight loss, it's very easy. You go to a bypass. That's a very easy one. Endoscopy doesn't have a role. In the middle, when you have abnormal anatomy but good weight loss, you need to look if you have hiatal hernia or dilated fundus. Endoscopy doesn't have a role there. This patient has to go to surgery. When you have strictures, kink, then endoscopy have a big role again, because we learn, especially with the strictures, if we dilate with achalasia balloon aggressively up to 3 times if necessary, 97 to 98% of these strictures are gone and the reflux is treated. So we have a role for endoscopy there. So we can create a stenosis for many reasons. Some of them we can repair, some of them don't. We published this in 2010 about the strictures, and we say there that we can do some things like knife myotomies, we dilate with a achalasia balloon. The editorial almost killed us, that we were crazy, that all the strictures have to go to bypass, but that's what most of the people do today. And that's what I suggest. You observe. If the patient cannot tolerate food, then you go for endoscopic dilation. I don't like seromyotomies. I spoke even with Jack Himpis. They are not doing it anymore. Some people converted to bypass very quick. But I like to think that you need to go and evaluate very well the size of the stricture, the length of the stricture, and when you have a small stricture that is not very long, always endoscopy has a role. When you have a long stricture, that is a very, very, very narrow. Maybe you will think it in the bypass already. How we do that? We do pneumatic dilation with a Galicia balloon. And I want you to tell you very quick what we do. We use fluoroscopy, we do endoscopy, and we are very aggressive. And I want to show you one case that has also a leak. You can see up there, there is a leak, what you see like purple. So remember, every time you have a leak, if it doesn't close easy, it's because you have a stricture or a high pressure system. So we identify the leak. And then as we advance, we're gonna look how strict it is, as you can see in the endoscopy there. So this one we're gonna dilate, because if we are able to reconnect and dilate all this body of the stomach, we will improve. Look at this stricture. We need to dilate that one, at least try to dilate them in 2 or 3 times to treat the fistula. As you move back, as you move down, start to open again. So you don't need to dilate that one. So look what we do. You go by fluoroscopy, you are in the endoscopy, you control exactly where you are. We use some clips as mark outside of the patient, so we know exactly where we are. And then we dilate with the balloon under fluoroscopy control until it opens. And yes, sometimes we like to see some bleeding there in the circumference, because it makes you did a good one. The GIs don't like to do that. They do a Galicia balloon for 2 minutes. We leave this balloon for 5 or 6 minutes with 35 psi, and that's very concerning to them. But look how it opened. And then at the end, you get a very good tube that probably will also help you to close the leak, and you treat the strictures. The leak is, as I hear some friends call it, the mother of all storms. The leak of the sleeve, for that reason, for the high pressure system, because you don't have vascularization there, is high. Even that it's been published that the risk of leak is up to 2.4%. This is the people who publish. What we get from other places that they don't do 50, 100 a year, they do 20, 30, the leak is higher. And then we need to define if it's proximal location, if we can manage by endoscopy, or what to do with it. And in the past, after we did the international consensus with the Cleveland Clinic, we decided that most of them will be treated with a mixture of dilation and stents. And as you are aware, we move away a little bit from that. Early ones, 7 days, we don't do much. We do like the bypass. From 7 to 14 days, we try to use stents and dilation. After that, they don't work much. The other thing we've been doing that is interesting is we either suture in place the stent, because one of the big problems of the stent, they move, as you can see here. We anchor that stent, and it's been helping a lot. The problem is the cost. The device is like $2,500 to put 2 stitches in a stent. So that's very difficult. But what we're doing is we use the device to suture the leak. And then above that suture, or in the luminal, we put the stent and we suture it. So we use the device for many things, suturing and stent, and it's been working for some of the cases. But when some of the group published this, the stents we have in the US are not good. We have to put 2. There are some very good stents in Korea and Argentina that have the shape of the sleeve. If you place it at the right time, if you fix them, there is a very low complication rate, but there is a very high success rate. But we need to move some other stuff. And as you can see, like this publication, is the pigtail. Some groups are using pigtails, and I think pigtail is the way to go now for some of those leaks after 7, 14 days before they become chronic. The thing with the pigtails, you need to take care more of the patient. I know some people are using vac sponges that keep the patient in the hospital for a month or so. You need to take care of that every day or every other day. With the pigtail stone, you can send the patient home, you can put the pigtail, then you can remove them. And as you can see here, again, you can use endoscopy, fluoroscopy, and you position very well the pigtails where you want them to be, and that will treat most of the leaks if needed. The chronic leak, we published in this SAGES manual a long time ago. There had been the second one, a gastric septotomy for the chronic abscesses and the chronic drainage. And also they almost kill us again. But that's what we do now. We do In a chronic fistula, we do dilation. We do, as you can see down below, septotomy, where we make sure that both holes, the fistula hole and the lumen hole, they are at the same level. So then gravity won't take it to the fistula, because the fistula is also higher here. So most of the gravity will take the leak to the fistula. If you lever them, then they go to both sides and the fistula start to close. And this has been working very well for our chronic fistulas. So this is scary, chronic fistulas. I've seen patients 2 years, 1.5 years in a hospital in Brazil, for example, because of chronic fistula. So we cannot do the same with chronic fistula like we do here. We put them in stents, we take them to the OR. This is the best example of what Einstein said. You don't expect to do the same thing and then get a different result. This is not going to happen. You need to do something different, because if it doesn't work, the septotomy, you ended up doing transection, big surgeries, total transection of the anastomosis, esophagojejunostomies, and that will be a problem. So for us, when we published in 2010 what you do for these patients, depends what you find, depends the patient history, depends why you're doing this to the patients. But more important, and that is my last slide, is surgeons like to think with their brain and with their heart. So surgeons, we have the tendency to think that one complication, one failure of a surgery, we can solve with another surgery. If you have a leak, let's do a surgery to prevent the leak. If we have a structure, let's do a surgery. We don't lose weight, do another surgery. We regain weight, do another surgery. I think it's about time that we think with the heart, with the brain, admit surgery is not perfect, and most of the problems we can solve between endoscopy, percutaneous intervention, radiology, and also will be much cost effective for the system and for the patient. Maybe it won't be that good for us economically, but it will be good for everybody. So I want to thank you again for the invitation. And I know it was a long topic, but I hope you kind of enjoyed. Thank you very much, guys, and good to see you, everybody.
Thank you, Dr. Zundel. It was a really very exciting, entertaining speech you gave, like drinking a Colombian coffee. I think I am having our Bangladesh Society of Surgeons President, Dr. Togidil Alam, to give the formal vote of thanks in this August gathering. Over to you, sir.
Thank you.